Hello everyone, welcome to the UK Anesthesia Network. I'm very glad to start the activity on the group by a presentation, and I encourage every one of my colleagues and members on the group to share their presentations if they like. So I'm Mahmoud Ali. I'm a consultant at St. Helens and Knowsley Trust, anesthesia consultant. I was before a pediatric cardiac anesthesia fellow at Alderhay Hospital, and before that at Freeman Hospital. So I would like today to talk about the pulmonary hypertension, especially in congenital heart disease. Um, Pulmonary hypertension, as a definition, is a mean pulmonary artery pressure of more than or equal to 25 millimeter mercury at rest. It can be categorized or divided into pre-capillary, post-capillary, and both. By the capillary, we mean the capillary vascular bed in the pulmonary circulation. So pre-capillary means mean pulmonary artery pressure of more than or equal to 25 millimeter mercury at rest, with measured pulmonary capillary wedge pressure of less than or equal to 15 millimeter mercury. Means that the pressure is high in the before the capillaries, but it is still normal or low after the capillaries. Post capillary means mean pulmonary artery pressure of more than 25 millimeter mercury at rest, and the pulmonary capillary wedge pressure is more than or equal to 15 millimeter mercury. So it means that the cause for this pulmonary hypertension may be already post-capillary in the veins or in the left atrium. It means after the capillary. So, and the pressure is, the high pressure originated from this area, and it is reflected to the pre-capillary area as well. There is another category, which is a long-standing or chronic post-capillary pulmonary hypertension that started to be reflected to the pre-capillary site, and changes in the blood vessels are transmitted now to the pre-capillary site. So it is considered like both pre-capillary and post-capillary. What are the causes of pre-capillary pulmonary hypertension? So the pulmonary blood vessels are very sensitive to the high flow or the high pressure, or high flow and high pressure, I mean. So from where the high flow to the pulmonary circulation can come, this is for congenital heart diseases when you have a shunt at any level between the left side and the right side. So some of the blood, instead of going to the systemic circulation, may shunt left to right and go to the pulmonary circulation. So there is some volume of the circulation is like recirculating again and again in the pulmonary circulation. We have a very important concept in congenital heart diseases, which is something called QP/QS, which is the ratio between the pulmonary blood flow and the systemic blood flow. In the normal circulation, the QP equals the QS, and the ratio of QP/QS is 1. But for congenital heart diseases, when you have a shunt at any level, so this shunt can cause left to right shunt or right to left shunt. If it has left to right shunt, that means the pulmonary blood flow will be higher than the systemic blood flow, and the QP/QS will be more than 1. But if you have a right to left shunt, so the pulmonary blood flow will be less than the systemic blood flow, and in that case the QP/QS will be less than 1. So the first cause for pre-capillary pulmonary hypertension will be high flow. For example, when we see a lesion like this is an ASD. So every time the blood comes from the pulmonary veins comes to the left atrium, the blood has the option to go to the left ventricle and go to systemic circulation, or some of the blood can escape because of the difference in the pressure between the left atrium and and right atrium, and some of the blood goes to the right atrium and go to the pulmonary circulation again, just coming from the pulmonary circulation in the pulmonary veins, and they will go again to the pulmonary circulation. So in this case, the QP will be higher than the QS, or the pulmonary flow will be higher than the systemic flow, and the QP/QS ratio will be more than 1. And in this case, the child will have A wet lung will have also like may have signs of heart failure. This situation is not as worse as when the pulmonary circulation is exposed to both high flow and high pressure. For the ASD, pulmonary circulation is exposed to just high flow. So the blood vessels will start to respond to this, but over long time to vasoconstrict reversibly. And after that, this reversible changes can be irreversible changes in the form of sclerosis, increase in the muscular mass, and hyperplasia in the intima of the blood vessels. So in this situation of the ASD, this takes long time and the changes are very slow, and the development of pulmonary hypertension takes long time. Uh, because in this situation, the pulmonary circulation is just exposed to high flow, but there is no high pressure. But when we compare this with lesions like VSD, we are talking about a big VSD that is not restricting the pressure in the left ventricle to be transmitted to the pulmonary circulation. Or for a patient like that who has a PDA and there is a communication between the aorta and the pulmonary circulation, so the blood will go from the aorta to the main pulmonaries and pulmonary branches to the lung. So in this case, the pulmonary circulation will be exposed to both high flow and high pressure, because the pressure in the aorta or the pressure in the left ventricle will be transmitted to the pulmonary circulation. So the situation is worse. The development of the changes in the pulmonary circulation is faster, and the development of hypertension, pulmonary hypertension, is faster in this scenario, in this situation. We are talking about a lesion that is big enough to transmit the pressure to the pulmonary circulation and big enough to give a high QPQS in both situations, VSD or PDA. So now we went through the causes of precapillary pulmonary hypertension, only high flow. We gave an example, the ASD, and high flow and high pressure, and we gave two examples, unrestricted big VSD or a big PDA. So now we're gonna move to the causes of post-capillary pulmonary hypertension. So the problem started in the venous side of the pulmonary circulation. So this can be a cause caused by obstruction in the veins itself. So the veins are abnormal, pulmonary veins are abnormal, obstructed by any reason, or in some congenital anomalies like the one that we will see in this slide. So this is a patient who has something called total anomalous pulmonary venous drainage or total anomalous pulmonary venous return. In this situation, the pulmonary veins coming to the left atrium uh, don't come to the left atrium. They just join together in like a confluence or like a bag, a big bag of a big venous bag, and this bag will be drained by a long vein, either in the superior vena cava or in the inferior vena cava, or sometimes these veins just drain into the right atrium directly. So the blood, instead of going from the pulmonary circulation to the left atrium, to the left ventricle, the blood goes back to the right ventricle, to the right atrium and the right ventricle. So in this situation, how the venous pulmonary hypertension will happen, this long vein is very liable to be obstructed at different levels, especially for the infracardiac, or when the long vein draining this venous bag goes to drain into the inferior vena cava. So because it is a very long course, and it is very liable to be obstructed at different levels. So if there is obstruction like that, the pressure in the pulmonary veins will be high, and this is a type of post-capillary pulmonary hypertension. There is another cause when you have here like a membrane or like something in the left atrium here that makes that divides the left atrium into two chambers. One chamber receiving the pulmonary veins, and another chamber is communicated with the mitral valve. And the opening in this membrane is small, So this causes like an obstruction to the venous flow from the pulmonary circulation as well, and this situation is called core triatim. So this can be a cause as well for post-capillary pulmonary hypertension. So we gave two examples of post-capillary pulmonary hypertension, congenital heart diseases, but also the second cause for post-capillary pulmonary hypertension can be in congenital heart disease and can be in adults as well. Actually, this is the standard cause of pulmonary hypertension in adult patients with cardiac disease. This is caused by it's not like obstruction in the veins, the pulmonary veins. It's just all the pressure in the left atrium is high because of any cardiac lesion. For example, mitral regurg, mitral stenosis, diastolic dysfunction of the left ventricle, anything that causes the left atrial pressure to be high, and this high pressure will be reflected back to the pulmonary veins, and it will cause post-capillary pulmonary hypertension. And if this is long-standing, and in chronic situations, this will cause a pre-capillary pulmonary hypertension as well, which is a third type of pulmonary hypertension. We said it can be pre-capillary, it can be post-capillary, and it can be both. So this is the third type of pulmonary hypertension. Uh, so now we talked about the causes, um, and now how our understanding of the high pulmonary pressure, pulmonary hypertension, and the increased pulmonary vascular resistance, how our understanding of this can help us to manage our patients. So we're gonna now talk about the factors that control the pulmonary vascular resistance, the factors that I can use as an anesthetist in theater to either increase the pulmonary vascular resistance or decrease the pulmonary vascular resistance. Most of the times you will need to decrease the pulmonary vascular resistance because you have a patient who has pulmonary hypertension already. But sometimes actually you need to increase the pulmonary vascular resistance, and this is for patients who has high flow, as we said, and this patient does not develop pulmonary hypertension yet, but this high left to right shunt and this high flow like makes the lung wet and exhausts the heart because it's a very big load on the heart, and you may think about increasing the pulmonary vascular resistance to limit this left to right shunt for the patient. So what are the factors controlling the pulmonary vascular resistance? First, the blood gases and the pH. Second, lung volumes. The third, maybe this is related also to ventilation, is the PEEP. The fourth is the vasodilator agents, whether they are intravenous, inhalational, or oral medications. And fifth is the sympathetic nervous system stimulation. So oxygen is a very, very strong vasodilator of the pulmonary circulation, and you can I can tell you when you see a report of the cath lab, and you see first they will uh, do the measurements of the pulmonary vascular resistance and the QPQS under normal circumstances when the patient is on minimal oxygen or in room air. And you will see in the cath lab report that the QPQS at this situation was like 2 to 1. That means that the pulmonary blood flow is double the systemic blood flow, and they will repeat all the measures again when you increase the oxygen to 100%, and also they will repeat all the measures again when you are on oxygen and when they add nitric oxide as well. So in this situation, the first reading was 2 to 1 QBQS, and you put the oxygen. Sometimes you find the figure very like impressive, like a QBQS of 20 or something like that. That means you increase the pulmonary blood flow to systemic blood flow from double to 20 times the systemic blood flow because you just increase the oxygen from room air or 25% to 100%. So this is the effect of oxygen, and you can use this on your side if you want to increase the pulmonary vascular resistance. Put the patient on FiO2 of room air, 21%. If you want to decrease the pulmonary vascular resistance, increase the FiO2 as you need. So the other factor is CO2. We know that the CO2, high CO2, uh, can cause uh, pulmonary vasoconstriction, and washing the CO2 will cause pulmonary vasodilation. It is the CO2 itself, and also it is the effect of CO2 in the pH. So increasing the CO2 will cause respiratory acidosis, decreasing the CO2 will cause respiratory alkalosis. So it is the effect of the CO2 itself on the blood vessels, and also it is the effect on the pH of the patient. The third factor is the pH. Whether this is metabolic acidosis or respiratory acidosis or metabolic alkalosis or respiratory alkalosis, it will affect the pulmonary circulation. So you can, for example, if you have a high pulmonary pressure, you will avoid the acidosis, you will avoid the hypoxia, you will avoid the hypercarbia, and the reverse, you may allow some alkalosis if you have if you want to increase the pulmonary vascular resistance, as we said, if you have a big left to right shunt. The second is lung volumes. So you can imagine the baby, the fetus, when there is no blood going through the circulation because the baby is not breathing. So all the blood vessels are like twisted and kinked, and that's why there is no blood is going there. There is no ventilation. So we expect that with low lung volumes, some of these blood vessels will not be patent enough for the blood to go, and this will increase the pulmonary vascular resistance. And the reverse is true as well. Very high, big volumes to the lung with high tidal volumes. This will cause squeezing of the pulmonary blood vessels and will increase the pulmonary vascular resistance. There is like a general concept that being around the functional residual capacity of the patient will give the best pulmonary vascular resistance for the patient. So the third is effective PEEP. You can use the PEEP to limit the blood flow, pulmonary blood flow. You can increase the PEEP to just to squeeze the blood vessels and decrease the blood flow to the lung. And if you have a high pulmonary vascular resistance, you should avoid high PEEP to avoid this effect. So the vasodilators, the problem with the intravenous pulmonary vasodilators that it is not limited to the pulmonary circulation, and it will have a vasodilator effect on the systemic circulation as well. If this is in your side and you need this, that's okay. But most of the time, you need something selective to the vasodilate the pulmonary circulation and not affecting the systemic circulation. So that's why nitric oxide comes as the first choice for as a vasodilator, pulmonary vasodilator, in case you have a problem coming off bypass, or you have a patient with high pulmonary vascular resistance and you want to help the patient with that. So inhalation of nitric oxide works because it is inhalational, because it just goes to the ventilated areas. So it is selective, and when it goes to the blood, it is very rapidly metabolized, so it doesn't cause systemic vasodilation. Sildenafil, the oral pulmonary vasodilator that can be used by the cardiologist, it doesn't have a big role with us as anesthetists. Um, Sorry. So um, the systemic nervous system effect. This is really important. You can, I would say, the best example to say about that is a patient who has a borderline circulation, a child who tends to shunt blood from the right side to the left side. So this patient coming off bypass, and this patient has a high pulmonary vascular resistance or borderline pulmonary vascular resistance, and you have a fenestration ASD, you have still a VCD, keeping it to vent the blood from the right side to the left side. Sometimes the surgeons leave this fenestration intentionally because like shunting some blood from the right side to the left side is better than no blood to go from the right side to left side at all. So if this patient has a high pulmonary vascular resistance, and we expect that this child will like struggle with this, so they may keep an opening between the right and left side for the blood to shunt from the right to the left side. So you can see when you make the child angry by any reason. I don't I don't mean that if the patient is under anesthetic and you are coming finish the surgery and you are moving the patient to the intensive care unit, for example. So this patient, you may decrease the sedation, you may stop the inhalation anesthetic. So if you start to wake this child up and the child starts to struggle, what will happen? Sympathetic stimulation. Sympathetic stimulation will cause vasoconstriction of all the blood vessels, pulmonary and systemic. The effect on the pulmonary blood vessels will increase the pulmonary vascular resistance, especially if this patient has already a high pulmonary vascular resistance, pulmonary hypertension. The blood vessels, pulmonary blood vessels in this situation is very, very sensitive to the vasoconstrictor stimuli, and it will respond aggressively to sympathetic stimulation. So if this child is not happy, we'll just squeeze the pulmonary blood vessels. So lots of blood will go to the from the right to the left if you have a fenestration or opening, and the child will be severely cyanosed. And if you don't have a communication between the right and left side, this may even affect the cardiac output and the blood pressure of the patient, because there is the blood coming from the right side to the left side is not enough to keep a good cardiac output and good blood pressure. So just keep the child happy. So these are the factors. So in summary, according to the lesion, according to the situation that you have, you may need to increase the pulmonary vascular resistance or decrease the pulmonary vascular resistance. If you want to decrease the pulmonary vascular resistance, use high FiO2, hyperventilate. You may allow some alkalosis, use low inspiratory pressures, avoid using high PEEP, and in case if it is severe, just use inhaled nitric oxide. So on the other hand, if you want to increase the pulmonary vascular resistance, if you want to limit the pulmonary blood flow, use a low FiO2, hypoventilate, and apply higher PEEP. And that's all. And thank you all for listening. And I hope this was useful. And see you in another presentation. I would like all the members of the group to try and share and make the group as active as possible. It is your group, and you are welcome to present anything you want. And thank you very much.